Hey, welcome back to Advanced Human Growth Anatomy. Today's dissection number 19. This is a big one, you guys. This one is going to be fairly memorable. I hope to be very impactful. An experience that will maybe stick with you for your lifetime. This will be quite an opportunity. Today we're going to be removing the scalp. We will be removing the calvaria to expose the brain, and then we will be removing the brain from these donors. This is quite a memorable experience, holy ground, you might say, to be able to hold this brain from the body. So I'm optimistic that this will be very memorable and a great lab for you, but let's get right into it. This is a cartoon that was given to me by an anatomy professor that I had in grad school. I thought it was so funny, I asked for a copy of it. She started the lecture by saying, and this is how we think the brain works. And just indicating that we know a lot about anatomy at this point, but the neuroanatomy is really still just exploding. The things we are discovering are really quite amazing. I work a lot in the pain industry as well, and so the not producing pain but dealing with pain, patients that are dealing with chronic pain, although PT can be considered pain producers too. But the neuroanatomy of how we experience the world around us is something that we continue to explore and discover, and it's amazing. So this is how the brain works. I hope you can you'll be quizzed on all these extension cords and where they go and what they're responsible for. So today, let's talk about the scalp. We've talked about it a little bit already, the glia aponeurotica, which is the Latin version of the epicranial aponeurosis right here, which is this. Looks like the slide got cut off a little bit there. Sorry about that. This is this top part here, this white aponeurosis. The frontalis connects in the front. And the occipitalis connects here in the back. Occipitalis is actually anchored at its origin on the occipital bone and has its insertion on the glia aponeurotica. The frontalis is actually anchored, the origin is off of this epicranial aponeurosis here, and then then it inserts down just above the supraorbital margin here. So it's responsible for raising the eyebrows, lifting it up. Here, the occipitalis, some people can kind of take their scalp and pull it backwards. Maybe some of you have good control of your occipitalis musculature. That's not something that I can do, but I knew a guy that could do that once, so that's an interesting party trick there. The pericranium is this layer underneath the skull here. So if you look at the pericranium, this bony structure underneath, what's interesting about this, the periosteum layer is what covers bone. And this generally has an osteogenic layer that will proliferate cells to travel to an injured area. Okay, so fibroblasts will be recruited, they'll be kind of brought in, those will become osteoblasts, and those will lay down new bone for growth and repair of the tissues here. What's interesting about the pericranium is it doesn't have an osteogenic layer, which means that if it's damaged, you'll need a graft from another area. You'll take a bone from another part of your body, or you'll fit it with a plate of some kind to kind of protect that area. But the epicranium or the pericranium does not have that osteogenic layer. The vertex of the skull is kind of right up here, the highest point. This is where you would rest a ruler. If maybe when you were a kid, if you got measured on the door or the wall or the door jamb, you can stand up tall and you'd rest a ruler kind of on the vertex here. That's what that is. Vasculature of the scalp is what we're looking at here. We've already seen a few of these. The supratrochlear artery coming out that supratrochlear notch up here, off of the ophthalmic artery in the orbit. Which is a branch off the internal carotid artery. But this travels through that trochlear notch and then distributes up onto the forehead here. Just lateral to that is the supraorbital arteries right here. Those are coming up onto the forehead as well, a little bit lateral to the supratrochlear arteries. And these ascend actually as high as the vertex. So you can see they kind of distribute up to kind of that top portion of the scalp there. The superficial temporal artery is a unique one. This one's coming right across here. It's a branch off the external carotid artery. External carotid coming up this way. It's going to branch and give this superficial temporal artery, which goes over the zygomatic bone. Right here. This is going to be becoming the transverse facial artery right there. Continues onto the side of the scalp coming up this way, and it becomes the superficial temporal artery coming up this way. So transverse facial and the superficial temporal. Posterior auricular arteries coming off here as well, again off of that external carotid artery, distribute behind the ear back this way, and then the occipital arteries coming back here, also a branch off the external carotid. They're going to supply the rest of the posterior scalp. So these arteries on the scalp, if they're damaged, they bleed a lot. So if you come across the scene or somebody has injured these particular vessels on the scalp, don't get scared. The external carotid is under a lot of pressure. So when these are branches off of the external carotid, there's a lot of volume that could come out of there. But just do your best to stop the bleeding. Do what you can to get them some care and some help, some pressure to stop that bleeding. Now, when we remove the scalp today, what we're going to do is make an incision. We're going to imagine a line here coming from just above that supraorbital margin and then coming across above the ear, kind of right at that, remember the external occipital protuberance, the inion? We're going to go just above that as well. We're going to cut along this line. So imagine that line from just above the supraorbital margin. You can feel that. Come back to that external occipital protuberance just right above there. Just kind of notice that spot. And then take your scalpel and cut on each side of the skull, on each along that imaginary line that you've just made. And then we're going to be able to remove the scalp. And when you do that, the skin underneath, you're going to be exposing this vasculature that we've just discussed. You probably won't be able to see the posterior auricular artery here. That's just it's too low from where we're cutting here, but you should be able to see the rest of this. Then what you're going to do is take a hacksaw. And the reason we don't use power saws, I'll talk about that later on probably, but you'll take a hacksaw here and you're going to just cut along. Once the scalp has been removed, the skin and the hair and such has been taken off, then you're going to take the saw and cut on that line that you've just made there. So don't go deeper than about a half of a blade's width. This will avoid the saw actually going into the brain tissue. We don't want to do that. But then once you kind of make that about a half blade width cut in the calvaria along that line all the way around, on both sides, then you're going to take a chisel and a hammer and get the rest of that, get it the rest of the way here. Okay, so you'll place the chisel in that groove that you've created by the saw and give it a good whack with a hammer, and then twist the chisel a little bit, kind of prying up, creating a loose edge around there. Once you continue all along that line until the whole thing is loose, then you'll be able to remove the calvaria and get a good look at the brain for the first time here. So let's take a look at the calvaria here. This is what you've taken off now. I'd love it to be color-coded like this, but it's obviously not. This is the cap of the skull, the calvaria. So it's made up of three bones here. There's a frontal bone, the parietal bones, and the occipital bone in the back here. There's a couple of words I want you to be familiar with: bregma and lambda. Bregma is the connection here where the frontal bone meets the parietal bone. It's right at where the sagittal suture meets the coronal suture, right there. That spot is called bregma, where those 2 points attach. Lambda, the Greek letter lambda, remember the lambdoid suture named for that, where the sagittal suture meets the lambdoid suture back here. That point is called lambda. And these are important landmarks when doing brain neurosurgery. So just to kind of give you some landmarks there. So you're going to cut along that line above the supraorbital margin, just above the external occipital protuberance, above the ear, above the zygomatic arch, and you're going to cut this free. You're going to create that space there. Now, what's interesting about when you take the calvaria off, you can see actually this diploid bone here, diploic bone. These where the marrow is in the skull. It's a spongy bone made from intramembranous ossification, if you remember your anatomy class. Endochondral is for the long bones and such. This intramembranous ossification is where we're developing this diploic bone. And there are veins in here that bring blood to and from the scalp, and they connect with emissary veins that bring blood into the cranium. And so it's possible, therefore, for an infection in the scalp to actually get into the cranium. So that's an interesting problem if it does happen, but that's where that can be. Now there's a groove. We've seen this before, the superior sagittal sinus. You'll see this right along midline here. And that superior sagittal sinus drains back to the confluence of sinuses in the back of the occipital bone there. And this is where cerebral spinal fluid from the subarachnoid spaces get absorbed into these sinuses in this area. And there are granulations that project from the dural sinus. You can see kind of where these are going to be formed. These are formed before the cranium ossifies, those granulations. And so as that cranium ossifies, it will sometimes get buried. Those granules will sometimes get buried within the bone here. And you can see kind of some of these, they create these paramidline pits here. These are from the arachnoid granulations, which are extensions of the arachnoid mater into the dura for cerebral spinal fluid to be reabsorbed. I think I've got a better shot of this. Maybe here I can show it. So you can see this is kind of a midline section. Here's that diploid of the skull. Here's those the Calvaria. Here you can see those diploic veins inside, going in to and from the scalp into the cranium here. And here's these arachnoid granulations, and you can see how they're formed before the bone ossifies. And so if that happens, you'll find these pits, these paramidline pits right here. Okay. So the dura mater, let's see. Yeah, I think we can. Let's go to this picture here. The dura mater, there are meninges here. There's 3 layers of meninges. The dura mater, the arachnoid mater, and the pia mater. Dura mater literally translates into tough mother. Mater, I believe it was, oh boy. I shouldn't have started this sentence without having it in my brain here, but Avicenna, which was a Persian physician, I think was the one responsible for naming these layers, and they thought this was where the brain and the spinal cord came from. So these were the mothers. This is where it developed from, is my understanding. The dura mater, the tough mother here. This is this outermost layer. I guess we'll just stick with this. Here you can see it kind of flipped up. Netter's drawn it with these hemostats holding it up like this. There's a middle meningeal artery kind of coming up into here. You can see through the meninge. This is a pretty vulnerable spot because it's we've talked about getting hit in the side of the head here. Remember the pterion, how that's a vulnerable spot too. But an injury to this area can cause a dural bleed. Now, what's dangerous about the dura is that it's very tough. It's like you almost can't stick a blunt probe through it. It's the material. It's like the material of your backpack. It's very tough, very thick, and so it doesn't give. But it's also, unlike the dura of the spinal cord, which is loose. This is actually adhered to the calvaria, so it's nice and tight. So when you take the calvaria off, you'll often kind of tear this, or you'll feel kind of the suction of this come off here. You'll tear it off of the calvaria itself. So there's really no space between above the dura and the calvaria and the cranium. There's no epidural space, no space above the dura, which makes blunt trauma to the head quite dangerous, because if you were to damage, for instance, this middle meningeal artery, some of these vessels in here, pressure would build up and pull the dura away from the inside of the skull as the bleed continues, and then that will press into the brain tissue itself. And epidural hematomas are fatal conditions if they're not released near immediately by drilling or kind of burrowing through the skull bone to release that pressure. This can be very, very dangerous. Now the layer right underneath the dura, so here you can kind of see the dura is over this granulation, and then right next to the calvaria here. Underneath that is this arachnoid mater right here. Now the arachnoid mater is named because it looks like a spider web. Kind of it's got a mesh to it, cerebral spinal fluid is beneath this layer. And these arachnoid granulations here, you can see them coming out here. These are projections of that arachnoid. They allow for reabsorption of that cerebral spinal fluid from the subarachnoid space, where the cerebral spinal fluid is, into the dural sinuses. And they create these pyramid-line pits that we've seen already as the bone ossifies over those granulations. This layer, this arachnoid mater, is waterproof. It doesn't let cerebral spinal fluid out, but it is kind of contained right inside there. And then the pia mater, which is the innermost layer here. I don't know if I have a great shot of that other than this. The pia mater is just right next to the brain. It's kind of in this thin green line here. This is what's going to go over the sulci and into the gyri, over the sulci and into the fissures. This is going to be right connected to the gray matter of the cortex itself. So it's pia is tender, the tender mother is the name for that. So again, let's look at this superior sagittal sinus. You can see right in this picture still that the dura is very tough, like I said, and it makes a fold on itself. You can see the dura coming on top, but then it kind of folds in on itself before it goes down and creating this falx cerebri that goes in between the hemispheres. And that where it creates that space in between, this is that superior sagittal sinus. So the space is actually created by that folding of the dura on itself as it comes down. And again, it comes down in between the two hemispheres to become the falx cerebri right here. The inferior sagittal sinus, let's take a different view now. And look at so superior sagittal sinus we've seen on top. This is what we were just looking at in cross section. Here's the inferior sagittal sinus here. At the bottom of that falx cerebri is that dura mater coming down in between the hemispheres. And then the straight sinus is what's connecting that posterior portion of the inferior sagittal sinus to the superior sagittal sinus. That's that straight sinus coming back into that confluence of sinuses right back here where they drain. And then from there on each side here, you're just looking at the right side obviously, but if you could see the left side, it would come around this way, this transverse sinus traveling horizontally on both sides from the confluence and becoming the sigmoid sinus. Anything that would look like an S, the Greeks named sigmoid. So that's this, remember the sigmoid colon, and there's other sigmoids. The sigmoid sinus comes down into here. From there, let's see where I am here. And that will eventually drain into the internal jugular vein right here on each side. So that sigmoid sinus is going to come down into there. Now there's also some other sinuses draining into the jugular vein. There's the superior and inferior petrosal sinuses. You can see the superior petrosal sinus here coming right into that sigmoid sinus, and then the inferior petrosal sinus right here coming down kind of underneath that petrous portion, coming down, and that drains right into the jugular vein as well. So you can see that here, superior coming kind of above in that middle cavity, and then the posterior portion of that cavity as it drops down into the posterior cavity here, you can see that inferior sigmoid sinus, or inferior petrosal sinus, and that again drains right into the internal jugular vein there. These are surrounding the pituitary gland. You can see that pituitary right here, where those are. The tentorium cerebelli is this, it looks like a tent. Let me find a better shot of this. Let's look straight down now, kind of over this. Here you can see the superior petrosal sinus right here coming into the transverse where it comes into the sigmoid, inferior petrosal sinus right here coming in right into the jugular vein there. Tentorium cerebelli, that's where I was. This is like a tent that cover. You can see it's dura again, but here it's taken out on this right side. It's still attached on the left. This is like a tent that covers the cerebellum. So we'll have to cut this. We'll talk about this in just a little bit here as we remove the brain. If you don't cut this as you're removing the brain, you're going to tear the brainstem and the cerebellum off. They'll be maintained within the skull, and we're going to try not to do that today if we can. So hopefully that's okay. The falx cerebelli, which is just right here. Let's find another shot of it. Here you can see the falx cerebri, and then it comes down. The falx cerebelli is going to come down. It's just part of that dura in between the hemispheres of the cerebellum. All right, there. The epidural space. Let's go back to this shot. Maybe maybe here. No, let's go to, oh boy, where am I? Here, let's go to this one. The epidural space is not an actual space. We talked about that it's adhered to the dura is adhered to the cranium here, so that there is no actual space between those structures here. The subdural space, though, this is the area between the dura and the arachnoid mater. And there, you can also have a subdural bleed here too. This isn't immediately life-threatening like the epidural bleed, but it can possibly, because blood can possibly come and drain from there into some of these subarachnoid vessels, but that still is something that needs to be addressed immediately if you do have a subdural bleed. But again, not quite as threatening as the epidural bleed because it does have some space there. Okay, I think that's what we want to talk about there. Let's now talk about the brain stem. Maybe just take a look at the brain here. Now, what's funny about these labels is it's like they were shifted. I don't know if I did that or how that happened, but don't get confused that this isn't the frontal, we're looking at the olfactory bulb there. The synapse point here for the olfactory tract and such. So you can see the optic chiasm is here, the optic nerve is here. Just like almost shift these over an inch or so, or however big your screen is to kind of get that idea. The brain stem is really these three structures here. You've got the medulla oblongata, which is right down here. Here you can see the olives and the pyramids on the side here. The desiccation of the pyramids would be here on the ventral portion where the axons are crossing to the other side. Pons varoli is this structure in the middle. Pons means bridge, to my understanding. The Greeks thought this was a bridge between the two hemispheres. It's not. They got that one wrong, but they still named it that, which is fine. So the pons is right there, and then the midbrain being above that before you get to the thalamus inside the brain there. So medulla, pons, and midbrain are the brain stem. We'll be able to look at those today. I hope we can get those out of the skull without damaging, but we'll do our best. Now let's talk about the cranial nerves. The cranial nerves are interesting. They come directly off of the brain and the brain stem. That's why they're cranial nerves. They were actually named by a Greek surgeon in the Roman Empire in the 2nd century AD by the name of Galen. And so we still use Roman numerals to name these, and that's where that comes from, because it was a Roman Empire surgeon. So we start rostrally from the nose, and then we go more caudally as we go back. And 1 through 11, we'll be able to see are pretty much back to kind of the olive of the medulla. They come from 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 are pretty much on the back side here. And then we swing around to the front side of the olive here of the medulla for 12. So a little bit interesting there. But let's take a look at these cranial nerves and just go through these fairly quickly here. But cranial nerve number 1, the olfactory nerve. This is a strictly sensory nerve. It doesn't. This is the only nerve that doesn't pass through the thalamus. It just goes right directly to the cerebrum for information transmission for the sense of smell. The bulb here of that. A lot of people call this the nerve itself. This is actually just where the synapses are happening. This sits right over that cribriform plate of the ethmoid bone, and that's going to synapse onto the olfactory tract. Neurons here actually go right back to they bypass the thalamus. This is why smell is such a powerful sense, because it's just it actually has less time. It goes right to the cortex. It doesn't actually go to the thalamus for a direction, a relay station. It just goes right to the cortex. The optic nerve right here, you can see coming from each orbit, coming from each eye. Strictly sensory as well. This comes from through the optic foramen in the orbit here, the posterior portion of the orbit. The fibers are going to cross at the optic chiasm, and that's why each eye produces a left and right field of vision. And this is unique in our binocular vision here, so that you can process it, the right field of vision from each eye in separate hemispheres. That the left field of vision goes to the right field of vision in the left hemisphere, and the right field of, and the left field of vision in the right hemisphere. But they cross. This information from the right side is going to actually cross and go to the left, and then the left is going to stay on that. It's going to be able to go to both sides. Both eyes are actually transmitting to both hemispheres. That was hard for me to say, but I think you got it. Now the third one here, the oculomotor nerve right here, this is going to be coming up. It's going to give motor innervation to the muscles that move the eyeball. Okay, so the oculomotor is a motor nerve. Trochlear nerve, right next to that, is going to be also motor innervation to the eye, coming from the bottom of the brain stem here. You can kind of see it from the bottom of the brain stem at that corpora quadrigemina. That's where that's coming from, and it's going to go again to muscles that move the eye. We've spent some time talking about the trigeminal nerve already. We've seen its distribution onto the face. This is a mixed nerve. This is going to be both sensory and motor. It acts a bit like a spinal nerve in that the fact that there's the nerve cell bodies here are kind of formed from the sensory neurons anyway, all contained near the base of it, kind of like a dorsal root ganglia, if you will. It's kind of right here, so that's unique. But it's got the three branches, and we've seen these already, the V1, and we name it V1, V2, V3 because of the cranial. It's again, Galen, the Roman soldier here, the Roman surgeon. Roman numerals. So fifth cranial nerve, V1, V2, V3. So the ophthalmic branch is going to come up here and go towards kind of the top of the cranium and the eye. There's a bit of the nose. The maxillary branch is going to go over the maxilla, and then the mandibular branch coming in front of the ear and then coming down through the jaw there. This is sensation to the face right there. Now, V3, the mandibular branch, also has fibers that go to muscles of mastication. So that's where we kind of see this picture here. It's going to the temporalis, the masseter. So you're getting motor activation there. That's why it's a mixed nerve, is because of the motor components from V3, the mandibular branch. Following it down here, here's kind of the front portion here between the pons and the medulla is the abducens nerve. This is a strictly motor nerve as well. Passes to the muscles for eye movement. So all three of those nerves, the trochlear, abducens, and oculomotor, 3, 4, and 6. I didn't say that in the right order, but 3 oculomotor, 4 abducens, 6 3 oculomotor, 4 trochlear, and 6 abducens. These are all going to muscles that move the eye. So the eye is actually this amazing structure, right? The fact that we can track an image or an object as it travels across our field of vision with both eyes, and one is abducting, the other is adducting, the other is going in and up, while the other is going in and out. The eye movements are amazing. So you can appreciate why there's 3 nerves specifically going to muscles that move the eye. A lot going on there. Now we follow this down there with 6. Number 7 is right here. This is the facial nerve. This is a mixed nerve as well. Give both motor and sensory. More laterally to the between the border of the pons and the medulla. You can see it here between the medulla and the pons on the lateral aspect. Sensory information. This is primarily motor, actually. It's primarily motor coming up to innervating muscles used for facial expression. So we've talked about that a bunch already, coming up into all those muscles we talked about on the face. That's where the facial nerve is actually giving them the innervation. But it gets its sensory component from that chordae tympani. Remember the chordae tympani here coming around this way? This is going to get exiting. Remember the petrotympanic fissure. I'm trying to remember. I think it's the petrotympanic fissure right behind the mandible. Remember where that exited, and that chordae tympani, that is actually part of the facial nerve. It's a smaller component, but this gives us that sensation, the sensory component to the posterior 2/3 of the tongue. I'm sorry, no, anterior 2/3 of the tongue. We'll talk about the glossopharyngeal in a little bit, but the facial nerve, because of the chordae tympani, is the sensory component to the anterior 2/3 of the tongue. Okay, keep going. Cranial nerve number 8 here, the vestibulocochlear nerve, right next to 7, right here. So you can see those 2 branches. That's chordae tympani. Is actually, it looks like it's 2 separate nerves. It's actually just all together considered the facial nerve. The vestibulocochlear nerve here used to be called the auditory nerve. If you learned that on old Olympus towering tops, a Finn and German, the and is auditory. We used to think that it just went to the cochlea. Then we learned later on, we discovered that how important this nerve is for balance and movement awareness. So the semicircular canals are also getting that information as well. So sensory information from those areas right here. Number 9, the glossopharyngeal nerve. Now, this is a mixed nerve as well, primarily sensation from the throat. If you have a sore throat, you can blame your glossopharyngeal nerve, cranial nerve number 9. It's a motor component. It's also used for a couple muscles used for swallowing back here. Okay. Vagus nerve. Now this is number 10. This is a big one here. Number 10 is not a big nerve, but it's on. Obviously, you can see this on both sides as we work through. But the vagus nerve coming down from the sides of the olive here. This is going to, vagus has the same root word as vagabond or wanderer. And you'll see that this nerve, we've seen it already as it comes down kind of in the pericardial areas, so it comes down through the diaphragm and then into the organs of the body as well. So it descends down from the neck and then gives motor pathways to the lungs, to the esophagus for swallowing, to the heart, to the GI tract, all the way down to the transverse colon. That's kind of where it stops there. Plus, it goes up into the liver, the spleen, the pancreas. It goes all over the place down there. And it has sensory information from these areas as well. Now, what makes the vagus nerve so interesting is that it's also 90% of our body's parasympathetic output. So activating that vagus nerve is an important part of rest and digest and heal. How do we calm the system down from increased sympathetic output? So there's a few ways we can talk about in lab if you like. A few ways to activate. I'm fascinated these days with activating the vagus nerve, and there's ways that we can actively do that in our daily lives. The vagus nerve is going to exit the jugular frame, and so did the glossopharyngeal nerve exited the jugular foramen. So there's a few nerves here exiting there, 9, 10, and 11 as well. So 11, let's talk about 11 here, the spinal accessory, or sometimes just called accessory nerve. 11 is here. This is going to be motor innervation. Only it's a motor nerve going to the muscles of the sternocleidomastoid and the trapezius. Okay, so those two muscles are where that's going to come. And it gets its origin actually from, you can see it, it's a funny nerve. It loops up from the upper part of the cervical cord and then loops back towards on the brainstem here by the skull into the foramen magnum and then exits down this way again through that jugular foramen to those two particular muscles. So interesting motor nerve here as it comes kind of from the cervical, but it comes up into and exits the brainstem, by the brainstem. And then the last one here you can see kind of sneaking around the front side here is the hypoglossal nerve here. So the hypoglossal is actually coming right off of the anterior, sorry, I was just pointing at the abducens, but don't mind that. The hypoglossal coming more on the anterior side, right by the in front of the olive here, motor innervation for muscles of speech. So sticking your tongue out. In the clinic, we would have people stick their tongue straight out. If it goes straight, that typically indicates they don't have a hypoglossal compromise. If it kind of deviates to one side, then we get a little bit more nervous if we're going to do any spinal manipulating or things like that. So exits right through the hypoglossal canal right here, kind of in the front of that foramen magnum. So it's going to come this way. Okay, how do we do so far here? So let's just give a quick review of the sinuses. Where the cerebral spinal fluid is reabsorbed here. Here's the superior sagittal sinus, if you remember. The inferior sagittal sinus sits right on top of the, right below on the falx cerebri. Deep veins tend to drain into here. Superficial veins tend to drain into the superior sagittal sinus. Then you've got the straight sinus, which is right here, draining into the confluence of sinuses. Here you can see this great cerebral vein, often called the the great vein of Galen, again named for that Greek physician, draining into that straight sinus as well. And then you've got the confluence of sinuses, the transverse sinus, the sigmoid sinus coming down here, superior petrosal draining into that where the transverse meets the sigmoid, and then inferior petrosal draining right into the internal jugular vein. Superior petrosal empties there. Inferior petrosal empties right directly into the vein here. These are actually kind of draining that cavernous sinus, and you can't really see that here. But if you were to look straight down here, maybe you can see it here. This cavernous sinus, here it is on each side. That's where that superior and inferior petrosal are draining. This is on either side of the sphenoid bone here. Here it's been removed, so you can see the cranial nerves underneath, but this sits on top of that tentorium cerebelli. Okay, let's keep talking about the brain for a little bit now. Let's go to this picture here of the brain itself. Here you can see the longitudinal fissure separating the right and the left hemispheres of the brain. Here you can see the brain itself, the gyri and the sulci is what I kind of want to talk about here. The gyri are these ridges, these bumps right here, these big gyri. They're separated by sulci that come down. And if there's a deep sulci, we call that a fissure on the side here. So the cortex, again, it's just this thin layer. If we look at it maybe from, nope. Well, I guess we'll just stick with this. The cortex is really just a thin layer, the gray matter on top. I think I did see a picture of that earlier. I'm sorry, let me just find it here. Well, it may not be worth the time here, but the cortex is just the thin layer on top where, here's a decent shot. Here's the cortex. You can kind of see that gray matter where the nerve cell bodies are. And the gyri, you can see on the top the sulci, the gyri, the sulci, gyri. Here's a fissure as it comes down. And you can see how the cortex, if it were smooth, you wouldn't have as much surface area. So these gyri and sulci magnify the surface area of the cortex a tremendous amount to give there a lot more space available for the gray matter, the nerve cell bodies. And they're organized, despite it's kind of looks apparently like or disorganized, but it looks random here. But there is. We'll talk a little bit about the homunculus, I think, next time, and how the organization of the neurons sit with motor and sensory input. But it does have a quite organized structure to it. So if we look back here at the kind of a cross section of the brain here you're looking at the right side of the cerebellum. Here's that tentorium cerebelli, and then here's the brain itself, the corpus callosum inside. This is the telencephalon. You can see the gyri and the sulci here. If we look at well, let's keep this one here for a second. The brain stem. Here's the medulla coming up through the foramen magnum. Here's the foramen magnum. Brain would be the spinal cord, and then the foramen magnum from here would be the medulla, and then the pons, and then the midbrain sits right on top of that. And then the thalamus, which is this relay station here, and then the hypothalamus, and then that infundibulum that comes down to hold the pituitary gland within the sella turcica here. So that's that the thalamus and hypothalamus is the diencephalon. The telencephalon is the rest of the cerebral hemispheres. So the cerebrum, it has nothing, and then the cerebellum here, right back here. The cerebellum actually has nothing to do with intellect. It's just, it deals with muscle tone and posture and coordinating movements and processing the information like that. But damage here won't produce paralysis. That's going to be more up into the frontal lobe here. We'll see that in just a second. But damage to the cerebellum will just cause lack of coordination. It'll be dyskinetic with movement. Let's look at the lobes of the brain now. If we look here, you can see the brain, to me, it kind of looks like a mitten with a thumb being the temporal lobe. You can see that portion right there. And then you've got the frontal lobe in the front, the parietal lobe, and then the occipital lobe. We've seen how the lobes just, they are named for the bone, or the bone is named for the lobe that's underneath. The same names here. The frontal bone covers the frontal lobe, the temporal bone covers the temporal lobe, and so forth. But the temporal lobe, hearing is going to happen here. Let me go to this picture here just so you can see a little bit of that information here. Hearing takes place kind of at the top portion of this lobe. Facial recognition is going to take place more at the bottom, kind of underneath of that lobe here. It contains the hippocampus, which is for memories. There's also a portion called the insula, and we've seen the insula. Here's a portion. You can see how the temporal lobe kind of it's found deep. This insula is found deep within the temporal lobe. It kind of folds on itself. How it kind of comes inside of there. I think it's an easier place to see if you do it in cross section. Here's a temporal lobe, and that kind of folds in on itself. And there's this other little cortex down here that's called the insula. It's again just part of that temporal lobe. The occipital lobe, processing visual information, right back here. The parietal lobes are this blue area. This is going to be for integrating and understanding sensory information like taste and hearing and vision and language. All of that kind of information is being processed back in through here. And then the frontal lobe, really, this is it takes all the information from the rest of the cortex and creates this ability for us to react. So it's going to give us, this is more of our personality and our executive reasoning, plus our motor control are more up into this area. This was a very reductionist way to understand the brain, but just kind of wanted to get through some of that area there. Let's talk about the ventricles for a moment here. This picture talks about the ventricles. Now this is going to be these hollow sections within the brain where cerebrospinal fluid is getting circulated. Here you can see the lateral ventricles, which are, there's two of them. There's a right and a left. Here's the left, here's the right, on the kind of a shadowed version on the other side. This is going to come up and around and then loop around to the side here. Okay, these make a big C right here. And this is from the frontal lobe. They're going to cut through the parietal lobe and then down into the temporal lobe as they kind of end here. There's a little bit of an extension into the occipital lobe back here as well from that lateral ventricle. The third ventricle is this portion right here. This is found between the two parts of the thalamus, so kind of right in the midline between the thalamus. Here you can see the lateral ventricles kind of in cross section here and here, and then they kind of loop. Imagine going back into the plane of the screen, coming back and around here. They would end up there. And then this third ventricle is right, here's the thalamus on either side, and that's going to be the third ventricle right in between there. And then the fourth ventricle is right here. This is right between the cerebellum and the brainstem. So cerebellum is here, brainstem is here. You can see where that's going to sit right there. The cerebral aqueduct connects the third to the fourth ventricle right there. And the interventricular foramen excuse me, connects the lateral ventricles to the third ventricle. So it's not 1, 2, and 3. These are just lateral ventricles. Then we go right to the third because there are two lateral ventricles. So lateral ventricles to the interventricular foramen, to the third ventricle, to the cerebral aqueduct, to the fourth ventricle, and then down into the spinal cord there. Now, cerebral nuclei are interesting. These are collections of nerve cell bodies, so they're found here. You can see them here. They're also found in the cortex itself. So if we go back to the cortex, here's some cerebral nuclei. These collections of nerve cell bodies we'll talk about now. But then here's the other portion where they're found. They're on the right at the cortex of the hemispheres. Okay, so within the thalamus itself. Go back to this shot here because cross section is mid-sagittal. I'm sorry, kind of a coronal section. That's what this is here. This is remember the thalamus is the relay station. This helps provide all of your movement, and a lot of other stuff is going on here as well. But this is going to be the relay station for information coming up from the brain, from the body to the cortex. The caudate nucleus. You can see right up on top here, the body of the caudate nucleus, kind of lateral, kind of right at the lateral edge of the lateral ventricle, and that's actually going to follow along there and get into that. The lentiform nucleus is actually two portions. There's a putamen and a globus pallidus on each side. So you can see this here, there's the putamen and the globus pallidus. That whole thing is called the lentiform nucleus. And the hippocampus actually It means seahorse. And you can kind of see where this it kind of folds up and around itself here. If you look at the bottom of the brain, looking from underneath here, you'll see this medial aspect of the temporal lobe. That's what we're looking at right here. This is that parahippocampal gyrus, which is immediately adjacent to the hippocampus. So parahippocampal, next to the hippocampus. This is kind of folded back on itself. You can see how it's kind of folded up on itself here, and then back right next to that lateral ventricle, where it would, with that edge right here, where that lateral ventricle kind of comes up. Imagine on the inside of this area here, that parahippocampal gyrus folding up on itself. And that's where we find the hippocampus. So some people look at that and they say, oh, that looks kind of like a seahorse. Can you see a seahorse in there? I guess that kind of does look like a seahorse. I guess that's why we'll call it the hippocampus. So damage to this area in particular will cause there to be an inability to form new memories. You'll see this sometimes with patients suffering from dementia or Alzheimer's disease, where they have good, vivid past memories, but they can't remember recent events or conversations. My wife's grandfather, before he passed, had this issue. I don't know if he had a stroke in this particular place or not, but he was so pleasant to talk with. I remember he would say thank you 3 times. That was one of my memories of him. You'd do something and he'd say thank you, thank you, thank you. He was just so kind, so grateful. But he could tell you with great detail the moment he met his wife of 60 some years. He could tell you how they met. He could tell you what she was wearing, what their first date was, what corner of the street it was on. But he didn't remember what he had for lunch 10 minutes ago. It was fascinating. He would ask the same questions over and over. So that short-term memory loss can come right into there. Okay, let's keep talking here about the nuclei. If we look at kind of a transverse section of that same thing, here you can see this is that caudate nucleus. Let's look at the caudate nucleus right next to that lateral ventricle. Kind of follows that along. And here it's going to come back. You can almost imagine it coming up now into the plane of the screen, coming around, and then hooking into this section on the backside here. Kind of coming all the way through. Here's kind of that tail of that caudate nucleus. Follows that lateral ventricle all the way till it ends at the amygdala. Here's probably a better view of it. Here's the nuclei. It kind of looks like, if we go back to this shot, it kind of looks like it would follow right alongside of that lateral ventricle, and it does. So that's where we're talking about that caudate nucleus coming around, and it ends right at that amygdala, this amygdalar body in the temporal lobe. And I could talk a lot about the amygdala, this cautionary center, the fear-generating center within our brain. There's a lot of stuff going on within the amygdala, which is right next to the hippocampus. Isn't that interesting? I think that's a fascinating structural relationship between the amygdala and the hippocampus. And we can talk about that if you'd like in lab. The lentiform nucleus. Remember, the lentiform is the putamen and the globus pallidus right here. Lentiform actually means lens. Now, think of like a lens of a ship trying to find shore. They thought this looked like a lens when they cut it in cross section here. I don't know that it does to me, but that's okay. Nobody asked me, and that's probably appropriate. But the lentiform nucleus here on each side, you can see the putamen and the globus pallidus. These again are these cerebral nuclei. And then the thalamus inside here. Here's that third ventricle, the thalamus on either side there, and then the lateral ventricles coming around. Okay. Now, go back to this shot here of the brain just to kind of give you another very reductionist version of what's happening here. So we talked about vision here, auditory 1 happening here. This is receiving auditory information. And then around there is this auditory 2, this association cortex that will tell you if you've heard that noise before. So if you're in a room with a bunch of little kids and somebody is crying or somebody yells, "Daddy," you can say, "Oh, that's my kid. I know that voice. I recognize that voice." So you heard it here and you associated it here on the sides there. The parietal lobe here, making sense of all the familiar information coming back in that parietal area. This is going to be patterning and sequencing and providing meaning to this information that you're getting in the parietal lobe. Occipital lobe, there's the primary visual cortex here, and this actually distributes. You can see it in cross section. The primary visual cortex actually comes all the way up into here. inside the middle here, and then the association of that coming along the other sides around it. So again, information distributes throughout the surrounding areas in the cortex to help with the meaning of what we're actually getting from sensory input. Corpus callosum, you can see this side right here, right in the bottom of that falx cerebri. This is connecting the two hemispheres for information transfer to go between each hemisphere, these association bundles of neurons. There's a primary somatosensory cortex. If you find the central sulcus, there's two big gyri here, separating the frontal lobe from the parietal lobe. The primary somatosensory cortex is just right. This is the post-central gyrus right here. This is there's a homuncular map. Again, we'll look at this next time, but this is going to be sensory information from the body and where it's coming from, particularly within the body. Just behind that would be an association area, so I can tell that I not only felt something, but I know what I'm feeling. In front of that central sulcus, you'll find the primary motor cortex, or the precentral gyrus, coming up here. This is going to be in the frontal lobe. This is going to be responsible for deciding how we respond to motor information. From all the sensory information that's been coming in, now we can respond to it. So sending motor neurons out through the pyramids of the medulla into the spinal cord and then out into the body to get the response that we're desiring. In front of the premotor cortex, primary motor cortex, is this premotor cortex. This helps with the sequencing of multiple muscle coordinations, with a certain action. So I'm not only getting a particular muscle to do its job, but now I'm going to coordinate a few muscles to do that job with the primary motor cortex, the premotor cortex. And then in front of that is the prefrontal cortex, and this helps with all of our executive reasoning. This actually, psychologists and sociologists will tell us that this actually doesn't fully develop until we're about 25 years old. So that might be discouraging depending on how old you are as you're listening to this. There was a biomedical teacher in the high school where my kids went to high school, and she would always tell people, she would tell the ladies in particular, now don't start dating until you're 25, because that's when your prefrontal cortex fully develops, right up into here. Actually, women, they say, develop a little more quickly than men, but neither here nor there. Okay, so damage this prefrontal cortex here might actually can cause inappropriate behaviors. You can lose your modesty. You can, cause and affect anger management. All those things can kind of be right inside here. So be careful if you have damage there. Maybe you'll meet people in the clinic or doing rounds in the hospital or memory care, something that has some issues with their prefrontal cortex, and it's not their fault. They're not trying to act like that. Sometimes they are. Sometimes you have control over this, but sometimes you don't. So be careful how you judge that. Okay, let's just review quickly here how we're going to get rid of, how we're going to remove the brain. Okay, so we've talked about this already, but let's go to this picture here. You can see the supraorbital margin. You can see the Indian back here, and how there you're going to make a imaginary line. You can make a scalpel cut right along that line above the ear, remove the scalp on both sides. Then you're going to take that hacksaw and you're going to saw on that line that you've made all the way around the calvaria here. Now, I would encourage you, don't saw very rapidly, so as not to create bone dust. We don't want there to be bone dust in the air. We're going to take extra precautions. We're going to use fitted N95 masks, and we're not going to use power saws to do this because that will produce a lot of bone dust. It's much easier, people doing autopsies and doing this, with a lot more volume. We're going to do this much more quickly and efficiently. We're going to take our time with a hacksaw because of that. Now, the reason we're doing this is because prions can exist in fixed tissue. Now, these are nasty proteins that we don't completely understand. They'll multiply and they create lots of diseases. And one particular mad cow is a big one we'd like to avoid by doing this. So the likelihood of acquiring mad cow is very small. Actually, I say that, but I have met somebody whose wife died in just within a year from me recording this, of a variant of that I think it's called uh, Creutzfeldt-Jakob disease. I didn't pronounce that well, but um, Creutzfeldt-Jakob, and but that's that mad cow. It's less than 1 per million is going to get this, so you don't really we're not worried about this. I'm taking an abundance of caution by talking about this. So there's about 5 million people in Minnesota. Minnesota gets roughly 5 million, or 5 cases per year. Out of a 5 million, we get five. This spongiform encephalopathy, it's called. So pathologists will use power saws their whole career and not have an issue. We're just using more caution than maybe is necessary to protect ourselves. So once you remove the calvaria, then you're going to come down and the brain will be sitting inside here. Actually, let's show this picture. What you're going to do is take your gloved hand in front of the frontal lobes. We've cut about here. And you're going to take it in front of that frontal lobe. You're going to kind of sneak around underneath and then gently pull up. Okay, and that's going to expose, now you're going to be able to see the olfactory nerve, the optic nerve, the oculomotor nerve, and these will all need to be cut in order to remove the brain. As you lift more of that prefrontal cortex coming up like this, what will happen here is you'll actually, we're going to tear, or we'll release that pituitary gland. That infundibulum holding it to the hypothalamus here just is not strong enough to hold. So it's going to be, we're going to lose that it's going to be maintained within the sella turcica. You'll be able to see the pituitary right inside here as we pull that back further. So just as you're pulling just as much as you need to here. We don't want to pull too very hard to get any of the stuff out here, because if you pull too hard here, then we're going to tear the brainstem. We're going to tear the midbrain, and then here's that tentorium cerebelli. We'll kind of we'll tear that off, and then that's going to release the cerebellum, and then we're just going to be left with the cerebrum here. And we don't want just the telencephalon. Okay, so now with a gloved hand, again, you're going to come down and release the dura. Let's go to this picture here. So we've come around here, we've kind of released, we've pulled back and we've cut the olfactory, the optic oculomotor nerve, and the pituitary is still stuck in that sella turcica. But now as you peel back, you're going to have to cut the dura right from the anterior to the middle cavity right here. Okay, that's going to allow you to be able to get that that frontal lobe, the thumb of that mitten coming out from here and under here. You'll be able to kind of get to the front of that to release it. Otherwise, you'll be tearing that as well. So releasing that from just underneath the lesser wing here, you can see, of the sphenoid. And then you're going to continue that cut on the back of the skull. Here you can see the tentorium cerebelli has been cut, and you're going to have to do that as well on the back of the skull as you release that. And then you're going to cut it. It's going to be adhered kind of to the top portion of this of the transverse sinus and the bottom portion. So it's going to have two areas where you're going to need to cut. But again, pulling from the side, so you can kind of pull from the side to get that cut on either side there. Otherwise, you'll not be able to release the cerebellum as it comes down. Okay, so releasing it from that petrous portion of the temporal bone is what we want to do. Let's see here, looking at my notes. Okay, so from there then, once you've released it from the front, once you've kind of pulled back, you've felt back, and you've released the temporal lobes from their portion underneath the lesser wings. Once you've cut that tentorium cerebelli from the petrous portion and coming around that transverse sinus, then you can start. Then you're going to actually put a finger down right inside and behind the body of the sphenoid and in front of the brainstem. Okay, and you're going to actually put a scalpel straight down into that area. You're going to take a scalpel and go straight down, and then it's going to be very deep. You're going to go down behind, or in front of the midbrain, in front of the pons, in front of the medulla, and then all the way down to the spinal cord. Now, if you need to grab a hemostat to retrieve that scalpel that you've cut down here, you can certainly do that, but cut all the way down. Now, what that will do is it will cut. If you can imagine it here, it's going to go straight down right here through, and you're going to actually cut the spinal cord. So you imagine a line cutting this way. And we want to cut all the way down onto the cord. So you can see how the handle of the scalpel might be here as you're actually cutting with the blade way down here. Oops. And so what that will do is release then the brain stem. So you've released the tentorium cerebelli, you've released the brain stem by cutting it here. Now, if you feel free, if you feel like you've got all of that loose, then what you can do is take, kind of put the the frontal lobe in the palm of your hand, and then kind of put a middle finger here, kind of along the front edge of the brain, holding the frontal lobe, and then put a ring finger and an index finger, depending on which hand you're using, to kind of grab around the temporal lobes here. And if you've released all of these structures well, you should just be able to pull back and just peel it, kind of roll the brain out of the back side of the skull through here. Then you'll be holding the brain. And we can walk through that in lab as well here. But hopefully that made sense, and if not, we can talk about it later as well. But yeah, it'd be very interesting to release those tissues and to peel back the brain, to pull it out of the skull. Now, I just want to touch base real quickly on Alzheimer's disease. Here's a brain. We saw how a normal brain should look. This does not look like a normal brain. And you might see this, depending on the disease process that these donors have had. At the ends of their life, you might find the hemispheres that look like this. You can see how the gray, the gyri here have just shrunk, and the sulci have become enlarged. And you should be maybe you'll see this today. This is a brain of somebody that suffered from Alzheimer's disease. So, whew, that was a lot. I apologize for the long lecture and all my talking, but I hope that was helpful. I hope you learned something, and I hope you're looking forward to this lab. This will be a very memorable one. Thanks for your time. We'll talk to you soon.